A little more focused on the medical management of these dogs, if and when you're choosing meds. Can you walk us through your approach to selecting drugs and how you work with them?
Yeah, of course. So, yeah, like I mentioned already, I do very commonly, I'd say like 90% of the dogs I manage, I will start them on around 1 milligram per kilogram per day of prednisone or prednisolone at the start of their therapy. In some cases, I'll go a little bit lower if they have previously had severe like steroid adverse effects, or if they're largely intestinal lymphangiectasia dogs. They tend to really just need anti-inflammatory steroids, so I try not to really go immunosuppressive. And then I'm also a person who maxes out my steroid dose at 60 milligrams. So if I've treated like a 55 kilogram Rottweiler and Newfoundlands with this disease, and I will max them out at 60 milligrams because, as everyone knows, the bigger the dog, the more the steroid side effects tend to be. So that's typically where I start, and then I usually taper by about 25% every 3 to 4 weeks, provided they're responding to therapy. But honestly, even if they aren't, because I don't keep going on steroids or dose escalate if there's no response, kind of based on my experience, largely of it not being helpful, and then based on some research that I've done, I tend to really focus on the diet. In some cases, I can taper dogs completely off their steroid and their disease can be controlled on their diet alone. Some of those dogs might have small relapses events, and sometimes we can put them back on steroids temporarily and then get them off again. That has been something I've experienced. And then I have some dogs that I can taper them down to kind of a half a mg per kg per day, or maybe even 0.2, 0.3 mg per kg per day. But if we try to go any further than that, they start to have their signs come back. And those are dogs where if they're tolerating their daily steroid dose well, then we can leave it alone. But more often, if they're kind of above physiologic, we'll actually switch them over to budesonide for long-term management. So I have a proportion of my patients that chronically take budesonide. And maybe after another 4 to 6 months of that, we might try to lower the dose again or take them off again. I usually say this doesn't mean that they'll definitely have to be on steroids for the rest of their lives, but just for another long while before we attempt it again. So I'd say most of the dogs I manage within 6 months, they're either off or on a very low every other day dose of steroid, or we've switched over to budesonide, kind of based on how the tapering has gone. For dogs who don't respond to steroids and thus I want to taper or try a different strategy, I typically will taper them off their steroids. I'll focus on diet. A lot of times those are the dogs that they need a home cooked diet and they tend to do much better on that. I also find that sometimes when I take away the steroid, the albumin gets better. The diarrhea can get a little better. I have theories behind why that is that are maybe beyond the scope, but I do sometimes think we're causing more harm than good. And that's largely why I've strayed away from cyclosporin, chlorambucil. Certainly don't ever use mycophenolate to manage this disease because of its effect on the gut health. So I really stopped largely doing that because my success with those medications was so few and far between. And I usually found that I was getting more adverse effects than benefits. And one thing I'll mention is I see a lot of people like afraid to they have a PLE dog that's refractory, it's still having diarrhea, its albumin's still low, and they're really afraid to stop that 2 mg per kg per day of steroid, or they're really afraid to stop the azathioprine they've started or the cyclosporin they've started. And I would just encourage you try it because you've got nothing to lose at that point. And my experience has been success in some of those cases and taking these dogs off those medications. And I think sometimes leaving them on, we're just getting chronic immunosuppression and the consequences that can come to that, which includes actually lymphatic dysfunction in some mouse models in chronic states of immunosuppression. So it doesn't mean I've never reached for it. In the last couple of years, I've tried cyclosporin in 2 difficult to treat PLE cases, but I didn't have success with either of those dogs. So I kind of proved to myself again and again that it's not usually a strategy that I personally need to employ. So I know that was a long answer, but we didn't get to talk about that in the talk. And I know that's important to a lot of people. So
thank you. Appreciate that.